Well, good morning.
Good morning.
It's always great to be at Whitman-Walker in your beautiful facility here on 14th Street. Thank you, Whitman-Walker, for your leadership in D.C. and certainly your focus on making all Washingtonians healthier. I am joined, of course, by your Executive Director, Don Blanchon. Give Don a big round of applause. HAHSTA Chung, who is the Deputy Mayor for Health and Human Services for the District of Columbia. Michael Carfin, who is the Senior Deputy Director at the Department of Health for HIV/AIDS, Hepatitis, and STDs. And Dr. LaQuandra Nesbitt, who is the Director of the Department of Health and is our doctor. Thank you, Dr. Nesbitt. So I think we were here 2 years ago, and we're back frequently talking about how we can better safeguard the health and well-being of every D.C. resident. And today we're focusing on meeting to discuss the many ways we are treating and preventing HIV in our community. HIV is a critical health issue that impacts too many Washingtonians. It crosses all socioeconomic lines. It knows no racial or religious barriers. And that's why we must work together to slow the pace of this epidemic. We talked recently about our plan in Washington, and it's a partnership with DC Appleseed, with the Washington AIDS Partnership. Together, we released the 90-90-90-50 plan. With this plan, we set 4 ambitious goals to end the HIV epidemic in the District of Columbia by 2020. So let me tell you about 90-90-90-50. 90% of all DC residents with HIV will know their status. 90% of persons diagnosed with HIV will be in treatment. 90% of persons receiving treatment will reach viral load suppression, and this means that HIV in their bodies is undetectable. And lastly, we will cut the number of new HIV cases in half, and all of this by 2020. I'm pleased to say that we've made considerable progress, but I don't have to tell you, there's more work to do. 2016 was the 9th consecutive year of decreases in new HIV cases in the District of Columbia. In fact, the number of newly diagnosed HIV cases in the district went down to 347. That's good news. And that's a 52% decrease from 2011 and a 73% decrease from 2007. All of our newly diagnosed HIV cases, people with HIV, are getting help more quickly. More people are getting connected to care faster, and they're starting and staying on treatment longer. And we are focused in our city on a treatment as prevention approach. And we should all be proud of this progress, but we should double down on our efforts as well. Today, D.C. becomes one of the first cities in the nation to support new HIV strategy called U equals U, which stands for undetectable equals untransmittable. And through this strategy, we're working to ensure that all residents living with HIV take their medications on a consistent basis. This daily routine will suppress the virus until it becomes undetectable. When that happens, a person living with HIV will not transmit the virus. People living with HIV have long borne the brunt of stigma associated with this disease, and now we will continue to work to make sure that they are empowered to take the lead on ending this epidemic. So we need your help to get the word out. We want to encourage everyone, no matter who they are, where they live, to get tested. If you're diagnosed with HIV, we want you to seek care immediately. And after you do, you have to take your medications and stay on them. You have every chance to live a full, healthy life and not transmit this virus to others. So I'm going to turn to our doctor now to tell you a little bit more about our efforts. Dr. Nesbitt.
Thank you. So good Morning, everyone. I am Dr. Nesbitt, and I want to thank Mayor Bowser and Deputy Mayor Chung for their continued support of our efforts in the District of Columbia and her tireless work to improve the health and the quality of life of residents here in the District of Columbia. We are here today for a number of reasons to share with you our annual surveillance report on the status of HIV, sexually transmitted infections, and other infections in the District of Columbia. As the Mayor mentioned, we have made tremendous progress as it relates to HIV, and we still have a way to go. I'm going to spend some time here briefly just giving you some highlights of our annual surveillance report, as well as sharing with you what we do here in the District of Columbia to continue to make that progress, and to share with you also the launch of our U equals U campaign in the district. I'd like to also acknowledge some of our great partners that we have that help us achieve all of this work, as well as Mr. Carfin and many members of our team at the Department of Health who work every day to make sure that we continue to make progress. Again, not only with HIV, but many of the other health conditions that also impact people who live with HIV in the District of Columbia. We have with us today Bruce Richmond from the Prevention Access Campaign, Murray Penner from NASDAQ, Walter Smith from DC Appleseed, Khalif Morse, who is the co-chair of the Ryan White Planning Council, Channing Wickham from Washington AIDS Partnership, and Charles King from Housing Works, and many other partners who are here with us today. In the District of Columbia, where there was a time when our HIV prevalence was around 3%, and we continue to make progress in such a way that we have just shy of 13,000 people living in the District of Columbia with HIV, which represents 1.9% of our population. That does still leave us above what is called the generalized epidemic by the World Health Organization standards. But again, we've made progress where we are markedly below that 3% where we used to be. And if we continue to make progress according to that 90-90-90-50 plan that we have in place, we can get below that generalized epidemic by reducing the number of new cases that we have every year. One of the efforts that we have in place that helps us receive national recognition is when we were able to implement fully a needle exchange program in the District of Columbia. And when we implemented that program in its current form back in 2007, we have reduced by 95% the number of annual cases of HIV infections related to injection drug use from 149 cases being reported in 2007 to only 7 cases related to injection drug use in 2016. So that's tremendous progress that we can be proud of, and a gold standard program that we are able to share ideas with other people who are just now able to get programs like that started in their jurisdictions. We also continue to make progress in the HIV care continuum, some of those 90-90-50 goals that we talked about. Between 2015 and 2016, we increased the percentage of people who are linked to care within 3 months. We also increased the percentage of people who are in medical care from 73% to 76% between 2015 and 2016, and the percentage of people whose viral load suppression, which means that the amount of virus in their body is undetectable, from 57% to 63%. When we look at people who participate in the Ryan White program, which is the program that the government funds for people who need support with their HIV care, those numbers are even higher, with 88% being retained in care, 95% being prescribed treatment, and 79% being virally suppressed in 2016. So those are really impressive numbers, and we know we can do better, and we'll get those numbers even higher in 2016. As Mayor Bowser stated, in 2016, the number of new cases of HIV that were newly diagnosed is 347. That is progress from where we were in 2015, a decrease of 11%. So we are well on our way of meeting our target of decreasing the number of new HIV cases by 50% in 2020. I do want to call your attention, however, to the populations that are most commonly impacted by new cases. The group most commonly impacted are African American men who have sex with men, followed by African American women, being the second highest group who is infected, who are our newly diagnosed cases in the District of Columbia. And then young people under 29 are more than 1/3 of new cases, around 36%. So when we think about the groups that we need to focus on in terms of making sure they understand HIV prevention strategies, those are the three groups that are where we have the most new cases. We continue to make progress as it relates to HIV. People who are living with HIV live longer, and we've decreased the number of HIV-related deaths between 2012 and 2015 by 48%. So again, tremendous progress as it relates to HIV. In HAHSTA, or HIV, AIDS, hepatitis, STD, and TB, we've worked on more than HIV, and you'll notice that in the annual surveillance report. And there's also often a co-occurring infection that we have between people with HIV and hepatitis. And while we work very closely with our academic partners, and we work very much both locally and nationally and internationally to find a cure for HIV, we found a cure for hepatitis. And we're working very diligently to get people tested for hepatitis. We have a recommendation that all baby boomers born between 1945 and 1965 be tested for hepatitis. And in our making progress toward doing that, we were able to diagnose around 1,400 new cases of hepatitis C in 2016. It's interesting with hepatitis C because we don't know if those were newly acquired cases in 2016 or people who have been living with hepatitis C for a very long time who were just newly diagnosed. And that number has been around the same number of new cases diagnosed annually for the past 5 years. Our focus in the district is to keep testing and keep finding people who are living with hepatitis C, because the more people we find, the more people we can get in treatment, and the more people we can cure, and we can prevent them from having long-term liver disease, decreasing their risk of ever developing liver cancer, and we can keep them here with us and improve their quality of life long-term. In the annual report, you'll see that we've developed what's called a hepatitis C cure cascade that will help us better identify those individuals, figure out what's the best treatment for them to get, and help reduce the number of people who are living with hepatitis C here in the District of Columbia. We're working very closely with all of our health plans to cure and eradicate hepatitis C here in the District of Columbia. I'll very quickly go over STDs and TB. We have made significant progress in tuberculosis in the district, decreasing by 32% the number of TB cases, and so that's some great news for us, but I'm now concerned about the number of other sexually transmitted infections that we have in the district. This is our third consecutive year where we've seen an increase in chlamydia, gonorrhea, and syphilis, and that's a cause for concern for us. It's a significant cause for concern because some people don't know that they have the infections. It can be without symptoms for some people. And when it's without symptoms and they don't know they have it, they spread it to other people, or the infection progresses in them and it can cause them problems with their long-term fertility. We really need to buckle down. We really need to make sure that we're encouraging people to go to the doctor once a year. Have a screening done, which can be the asking of questions and identifying their risk. And the screening for these STDs sometimes can be non-invasive, meaning that it cannot hurt you physically to have these tests done, and the treatment can be a one-time quick treatment, but it can markedly improve your quality of life and reduce your long-term risk for infertility. So we want to make sure that people understand that. For some of the infections, they're more common in men, and others, they're more common in women, but our most impacted age groups tend to be 20 to 24. The good news is we are reducing the rate of these infections in our adolescents and school-aged children. So that's really good news for us year over year, but we've got to make sure that our 20 to 24-year-olds are getting this message and hearing it very loud and clear. So that's a focus for us in the coming year. So how do we do all this good work? How do we make these things happen? Well, we've done a really good job of working together with all of our Medicaid programs and all of our healthcare providers like Whitman-Walker Health, and we've publicly supported over 145,000 HIV tests in 2016 in the District of Columbia. We've distributed over 6 million male and female condoms in 2016. The Marion Barry Summer Youth Employment Program started yesterday, and I had the opportunity to speak with our cohort, and I remind them that there's always a place to pick up free condoms around the District of Columbia. And these 6 million condoms, you have access to them. So we can get that number even higher. I have no spending pressures related to distribution of free condoms. We've also supported more than 1,000 persons to obtain access to pre-exposure prophylaxis. That means identifying people who have a risk for HIV and getting them on treatment before becoming HIV positive. We talked to you all back in December about that initiative, and even more people are getting access to PrEP through partners like Whitman-Walker Health. We've removed over 800,000 needles from the street in 2016 alone through the DC Needle Exchange program that I've referenced before, which is why we're able to drive down that rate of people who acquire HIV through injection drug use. We provided STDs testing for over 6,200 youth ages 15 to 19 years old through school-based STD screening and community-based screening programs in 2016. And we provide HIV medical care and support services to over 8,500 individuals through the Ryan White Care Program. And that represents 2/3 of people in the District of Columbia who are living with HIV. So those are just some of the ways that we work together with our community partners to address HIV in the District of Columbia. Now it's time to talk about U equals U. So you all have had the opportunity to see some of the campaign materials here. This new campaign is based on science, confirming that persons with HIV who take their medications consistently and achieve viral load suppression, which means that we often refer to as the virus being undetectable, do not transmit HIV to others. The evidence comes from a National Institutes of Health funded study known as HPTN 052 that examined over 3,500 participants at 13 sites in 9 countries. The results have launched a worldwide initiative led by the Prevention Access Campaign, and it is endorsed by over 260 organizations from 29 countries, including Whitman-Walker Health. And the Department of Health and the District of Columbia will be the second health department in the U.S. to endorse this approach. DOH, we really would like to thank Bruce Richmond for his support from the Prevention Access Campaign for providing us advice as we develop this campaign, and also for NASDAQ with the leadership of Murray Penner for providing advice and support to us as we move this campaign along. So you'll begin to see this campaign around the city on buses. We're going to have an app. All of this will begin to launch this month, and just another way of making sure that individuals living with HIV understand that they are a part of us continuing to make progress here in the District of Columbia. So U equals U, and we're very proud of the progress that we're making, and undetectable equals untransmittable. So I'm really happy about this, and we'll like to bring up Don Blanchon now to share some words about why Whitman-Walker got really excited about U equals U.
Thank you, Dr. Nesbitt. Welcome to 1525, everyone. I'm glad you're here. Mayor Bowser, thank you as always for being here, for your leadership. Dr. Nesbitt, HAHSTA, Sheila, Michael, I could name probably 70% of the people in this room because it takes a village to do this work. What a difference 10 years makes. Yes. And both the mayor and Dr. Nesbitt talked about kind of where we were back in 2007. 1,300 newly diagnosed individuals that year, 4 a day. And then fast forward 10 years, a 73% reduction. We're less than 1 a day now. And I just wanted to mark time. We've been marking time in the passage of Jim Graham the last 2 weeks. Yes. And I wanted to mark time in the sense of the last 10 years. Needle exchange, massive condom distribution, great public messaging about public health and taking care of yourself and empowering around your health. PrEP, the community coalitions that the city has helped building and how we actually get to people who aren't in care or aren't taking their meds regularly. A lot of really good science, and when you put that all together, you've got a really strong response, and that's what you're seeing 10 years later is a really strong response. And I wanted us, we have so many things we deal with every day, and I just wanted to mark time by saying it's a great 10 years, and we're not done yet, and we have more work to do. One of the things I wanted to comment on is just the community it takes to do this. And just to give you a size and scale, I think Whitman-Walker is about 35% of the Ryan White work for the city. But that means that 65 to 70% is going on somewhere outside of us, which means it's not all about Whitman-Walker. It's about other people in this room, and I can name people again. It's about a group of people who are testing in faith-based groups and schools and all over the place. And it's really been this issue of a steady messaging around what it means to empower people about their health, and particularly their sexual health. And we've seen that progress. Now, the work we have in front of us is really around a group of people who, for whatever the reasons, the interventions and the offerings we have in community right now aren't getting to them. And so, one of the milestones, and Dr. Nesbitt mentioned this, is we think about PrEP. Well, we think about PrEP largely around gay men. We need PrEP to be thinking about women and young people. So we've got to think about what that means. And our institution, as a major provider of PrEP, needs to think about what that means for those cohorts, because that's where there are new infections coming from right now, and that's where we need to do more to protect people. The other area is that I want to highlight the work that the Washington AIDS Partnership has supported us on, which is a home-based model, a home visitation model for people who aren't retained in care. And that's showing really wonderful preliminary results. I just want to thank Channing, Wickham, and the partnership for supporting us on that. So much so that we have a poster that's being presented at the International AIDS Society's conference in Paris this summer, showing real strong signs. 350 to 400 people who, for whatever reason, can't stay regularly in care and take their meds, and just going out to their home or where they want to be and trying to get to them about what can we do to help you. Does that mean we have to do direct observed therapy in your home? What do we do to get you just to do these small things every day to take care of yourself? And those are the types of things that are going to help us bring 347 down to 0. We've got 90% of what we need, and now we need the next 10%. So I love the 90, 90, 90, 50, although I always forget the 50. If you could think about that 10% of a group of people that we really need to figure out what's the next level of interventions. And you all have done an amazing job with the support of the district government, with the leadership of the mayor and the Department of Health under Dr. Nesbitt. The issue is, how are you going to help us with the next 10%? What are we going to do to get that done? So in closing, I'll just say the work hasn't been done. It hasn't been done for a while. I hope you leave here feeling really good about the progress we've made. We spend a lot of time in public health beating ourselves up because we aren't where we need to be. This is tremendous progress over a decade that cities would be envious of and communities would be envious of. We should take pride in the moment and then work our you-know-what off in the days and weeks ahead to figure out how we're going to get that remaining 10% in care. Thank you very much.
Thank you. So thank you, Dr. Nesbitt, for that update on where we are with the numbers and the challenge also that both you and Don have laid out for all of us and working together. So we are happy to take a few press questions on topic, and then I'll be available for off-topic questions, but I won't be available after I leave the podium. Okay, so any questions? Okay. Off topic.
Sunday evening, here in D.C. and I think in Maryland as well, there were a number of ATVs, and ATVs.
Where was he going with that?
Well, alphabets. Anyway, ATVs and dirt bikes. They were buzzing
vehicles, just to be clear. Okay.
And they were buzzing, I think, K Street, H Street, a number of areas around the city. As I recall, the city, through the police department, launched a campaign, I guess, a year or so ago to deal with this issue. I just wanted, one, to get your assessment of how this has worked, and two, what did you think about what happened over the weekend, and what is the city doing about it?
Yeah, thank you for that question, and it is a question that I think that we're going to have to deal with every year. It's kind of perennial. One of the things, though, that we launched last year and will continue to focus on is going to the source of where those bikes are. Where are they being stored? Where they're being fueled? And a lot of it has to do with getting to the bikes where they're being stored. We and the police use a lot of investigative techniques. I think you'll remember last year we took the photo surveillance that we have. We put the photo surveillance out, and we got a lot of compliance from the dirt bike users and their mothers. And so we were able to confiscate a lot of the illegal dirt bikes, and we will follow a similar approach. We encourage our regional counterparts to do the same. We find that a lot of the illegal dirt bikes are being stored outside of the District of Columbia. A lot of the users, now we have our own, don't get me wrong, but a lot of them are being stored outside of the district, and people coming in the district as well to ride them illegally. We're concerned about it because, number one, those vehicles aren't meant for the roadway. And sometimes when you have big groups like that, they're driving them recklessly, and they scare other drivers, and they don't follow all the rules. So that's why we're really very concerned about it. So we will be aggressive about going to the source and finding those bikes.
And their mothers. What did you mean exactly?
Well, I mean, a lot of if you see your kid, who's generally a good kid, on TV with their picture, you don't want your kid to get in trouble, okay? And so if you know that dirt bike is in your shed or stored in your yard, or if you're a gas station owner who's allowing big groups of people to fuel up at your gas station, we have a number of people who want to see some resolution to this. Yes.
And then I have two questions.
And you are?
Rachel from the Washington Post.
Okay, Rachel.
So the first one is just, what's the benchmark year for the 50% decline? Like the 50%
Dr.
decline?
The benchmark year for the 50% down was 2015. The first year that we started out with the report. For 1950, the year that we released it or began the initiative.
And then the second one is just, what role, if any, do you think that changing city dynamics and gentrification play a role in the declining numbers?
So we actually, in the surveillance report, we actually track people from moving in and out of the district. So when we report our numbers of the prevalence, we account for people who no longer live in the District of Columbia.
Thank you.
Yes, sir.
Hi, Ace Robinson, the steering committee. Very similar question. Have you been able to speak with your peers, the other mayors in the cities nearby, about like how to increase this through the DMV region? Like, to have this initiative be region-wide as opposed to a city-wide when we're looking at Bowie County, Arlington, wherever people are living.
So we are the administrators of a regional Ryan White program. So it actually includes 4 states, Maryland, Virginia, D.C., and West Virginia, one county in West Virginia. And we restructured our Ryan White program to allow for people to be portable between 4 states. So we account for the fact that people may be transitioning in and out of one state or the other so that their health care can also be portable. We didn't want to have a very district-centric approach such that if people moved from D.C. to Maryland or D.C. to Virginia or vice versa within a couple of months, that they would be cut off from their healthcare services. We wanted the services to be able to follow the person, to be very comprehensive in that regard, because we know that their social networks may not necessarily change even if their residency status changes. And it was more important for us to keep people linked to healthcare services and social support services, which Ryan White also covers and provides. So our program has transitioned in that regard over the past year and will continue to do so in a number of facets to be able to account for that. Also, there's a way that data is provided and supported nationally, in ways that we are working on doing a better job of that. So if people move into the district, we don't count them as a new HIV case. We just count them, we consider them to be a person who was already diagnosed. Their data is just new to us because all HIV labs come to us, but we want to know, maybe you were diagnosed in 2007, just moved to the district in 2016. Just because we're seeing your lab for the first time, we don't want to count you as a new HIV case.
Need to make sure that the local health jurisdictions can communicate freely? Is there some support you guys need to make sure that happens in an easier way? I imagine everyone has a different health informatics system or something like that.
Yes, so we have a way where Mr. Carfin is a member of NASDAT, and we also have where the HIV directors in the region meet together, and they have a way to be able to reconcile those data differences and support each other.
But let me just add on to your question, because I think it's a good one. I am part of of course, a network of mayors, but more importantly for the district, I meet regularly with the governors of Maryland and Virginia. Most recently, we met about another health epidemic around opioid use. And I take your note. I take your note because I think that we don't want this issue, fighting HIV, to fall from that level of political discussion. And so I'll keep that in mind for our future meetings.
Thank you.
Yes.
Talking about politics, the needle exchange, you said that the number of HIV cases related to needles, or I guess drug needles, has decreased 95%?
Yes, since 2007.
Since 2007.
Yes.
I mean, there's also seems to be this thing in Congress to cut off the funding for needle exchange in D.C. Is that affected, or is that beyond the congressional issue?
I handled a political question. It is stunning. Stunning. What was the number in 2007?
146.
146 down to 7. And we know that we can combat that. And prior, you will remember that the Congress blocked a needle exchange program in the district for 10 years. Blocked it. So all of those lives that were impacted by HIV could have been prevented. So I think that the lesson is clear, that we know our city, the laws that we pass have to be respected by the Congress. And the Congress, and I don't know all of the details of what the new Senate plan will do, but I was also reminded in an earlier question about the impacts of health care coverage in other states, how that can influence us. We've been committed, robustly committed, to covering our residents. And we want the states that surround us to have access to high quality care as well. Can you imagine? We're telling people to go get treatment and stay in treatment. And at the very same time, we're telling, well, I don't know if you're going to have health coverage. Well, I don't know how pre-existing conditions are going to be covered. Well, I don't know if you can stay on your parents' plan until you're 26. I just don't know. I don't know if Planned Parenthood is going to be around to help you. Just don't know. And so that is the discussion that the Senate is undertaking now, and it impacts us. I feel confident that we're going to do everything that we can to keep our people covered in the district. But what about Maryland and Virginia? What are they going to be able to do? So it's an important question.
So the needle exchange program will continue here in D.C.?
The needle exchange program is not under threat. And now keeping in mind that the Congress can always add riders, but we don't have any reason to think that they are revisiting something that's been settled 10 years ago. Yes, we'll take a couple more questions. Yes, sir.
Ken Dominguez from CDC, Division of HIV/AIDS Prevention.
Thank you, sir.
Thank you. I had a question regarding the issue of youth and challenges and potential strategies in relation to PrEP here in D.C.
is that the entire question, or?
Yes, I mean that's one of the target areas in terms of future target areas, and I was wondering if you guys had any ideas about, what are those challenges and what are potential solutions.
So here in the district, we have opted to create an entry point into PrEP at our DC Health and Wellness Center, which is also a site that we provide services to youth in the district for other STD and STI related services. Our goal at that center is to then transition their care to one of our other health centers that are where we have providers who are skilled in being able to provide PrEP. To date, we have not ascertained that there is a barrier related to creating access for youth here in the district for PrEP.
Okay, last question.
Hi, John Hassel, AIDS Healthcare Foundation. Mayor, you commented about the Senate plan. I think nationally 42% of people living with HIV depend on Medicaid. Do you have any comments about what their plan is for Medicaid?
Well, again, I don't know the specifics, and I think they change minute by minute about what the Senate majority thinks that it can get through. I think it's clear that they think that Medicaid should be a benefit that is earned. And I think that is the kind of the crux of the issue. Do you think poor people should have access to health care or not? And do you think that they should qualify for a government benefit? So I think that their focus is on the very poor and on people who live with disabilities. And we're at 200% of the poverty in D.C. for Medicaid. And so that allows us to get to like 99% coverage in Washington, D.C. And I firmly believe that people who have access to health care and don't have to live day to day wondering if they get sick, will they have access to care, makes every part of their life better in the District of Columbia. So that is our commitment. Okay, thank you, everybody.